Thank you everybody for joining the webinar, COVID-19 and Diabetes, What We Know and What We Don't. This is the recording of the webinar that will be shared with people who were not able to attend the initial session. Let me turn it over to our moderator, Dr. Sarah Hallberg. Sarah?
Hi, I'm Dr. Sarah Hallberg, Medical Director at Virta Health. And first, I would like to welcome everyone here today and thank you for joining us. We have all found ourselves in this new and surreal situation over the past few weeks. No doubt for people, this has brought some degree of fear and anxiety, but hopefully a few silver linings as well. For those of us who come into this situation with conditions that could put us at higher risk for complications from COVID-19 or who care for someone who is, the fear and anxiety can be even greater. As with anything related to health, the first thing most people do is search for answers. The problem currently is that due to the fact that COVID-19 or coronavirus is a new virus, there are more questions than there are answers. This can be very frustrating and make wading through what seems like an endless stream of often conflicting information even more difficult. I'd like to take a quick look at why recommendations and guidance are so difficult right now. So in front of you is something called a hierarchy of evidence. In medicine, as in all science, we look not just at the data, but where the data came from. The quality or rigor of the evidence is critical to make good clinical decisions. Here is a widely accepted hierarchy of evidence. We usually make decisions by focusing on evidence generated from sources at the top of the pyramid, which is considered high quality evidence. However, due to the case here being such an acute condition, in the middle of this health crisis, there has not been evidence that falls at the top of the pyramid, which means that we are relying on evidence sources from the bottom of the pyramid. And this is creating quite a conundrum, as it is difficult, if not impossible, to give definitive answers to so many questions that are swirling around right now. We are forced to recommend and try things that have not been rigorously reviewed. This is far from ideal, but is the reality we are currently operating in. Doing nothing is not an option. Today, we bring you a panel of experts in diabetes, infectious disease, health literacy, and telemedicine to help provide you with a straightforward assessment of what we know and what we don't know about diabetes and COVID-19. Before we begin, I would like to acknowledge and thank all the healthcare workers in this country and around the world who are risking their own health to help us deal with this crisis. Today we are joined by Dr. Ann Peters, Kelly Close, Dr. Bob Radner, Dr. David Harrison, and Dr. Lisa Fitzpatrick. Dr. Fitzpatrick is a medical doctor who has worked at the Centers for Disease Control and Prevention. Her career has spanned research, clinical medicine, global health, health education, and patient advocacy. She recently served as the medical director for Washington, D.C.'s Medicaid program and clinical professor and professorial lecturer at the George Washington University School of Medicine and Milken Institute of Public Health. She is a member of the Aspen Institute Global Leadership Network and was selected as a 2017 Aspen Institute Health Innovator Fellow. She founded and is currently serving as CEO of Grapevine Health, an exciting new organization focusing on health literacy. Thank you very much, Dr. Fitzpatrick, for joining us.
Thank you, Dr. Hallberg. I appreciate the opportunity to be with you and kick this session off. I'm talking about COVID-19. As a reminder, coronaviruses have been with us for ages, and there are 4 strains that are well known to us because they cause the common cold. But this strain is new because we've never seen it cause disease in humans before. And I'm sure it's frustrating. There's a reason there are so many unknowns. And the reasons we rely on individual experiences to describe what we expect to happen with this virus is all related to it being a new virus and a new experience for all of us. Next slide. So what do we know about the novel coronavirus and COVID-19? Well, we know it spreads faster and more efficiently than cold and flu viruses. We know a person with COVID might infect up to 2 to 4 people, although that number is being revised as the epidemic wears on. But other viruses, the flu, for example, generally spreads to 1 to 2 people per person. So this gives you some idea of how much more quickly we can see spread within the community. But the good news is 85 to 90% of people who contract the coronavirus and develop COVID-19 will easily recover within 2 weeks. And even people with chronic health conditions like diabetes will recover. The challenge is most of the information we're hearing and seeing on TV, the discussions we're having are about the high mortality. But it's important for us to remember that most people do survive infection with coronavirus and COVID-19. Worldwide, severe disease has been seen in people over the age of 60, and in some places seems to be greater in men, people with heart disease, diabetes, and other chronic health conditions. But severe disease in the US, while similar in some respects, it doesn't strictly follow these patterns. It's still true that the most common health conditions we're seeing in the US are associated with chronic lung disease, diabetes, and heart disease. But just yesterday, the CDC released a report from a review of a sample of COVID patients. And they looked at the results of, or the outcomes for all of those patients. And when they looked at people with severe disease, they found that only 37% had underlying health conditions. So I think even though it's a small sample of people with COVID, this is good news, and it reiterates the point I just made that even though we know people with chronic health conditions are at higher risk for severe disease, it's not uniformly so for everyone with diseases, with chronic diseases. So that's really hopeful information. And also when CDC looked at those who required hospitalizations, the number did go up significantly, but still it wasn't uniformly so for everyone. We don't seem to have a male predominance in the United States. There are some speculations around why that might be. I wonder if we will eventually find a link or an association between smoking and or vaping and chronic lung disease in people who are younger than the 60-year cutoff we've seen in other countries. It's possible the level of control of underlying health conditions affects the risk for severe COVID. So for example, if a person with diabetes has the condition under control, it could be this might protect a person from developing severe disease. So I think these are all potentially reasons to hope for good outcomes for people with chronic conditions. Next slide. So what don't we know about COVID? And this I know is frustrating because it's such a new virus. We're learning, and a lot of the information is changing, which can also be frustrating. We're not sure how long it's been here. Based on the timeline from the WHO and the CDC China office, they detected cases in China as early as December, or the first week of December. The first case in the hospital was diagnosed on December 10th, which suggests there was transmission happening well before that. People often want to know if this is seasonal and will we see a reduction in transmission and spread with the warming of the weather. And that's also unclear because we're seeing cases in warm climates such as Singapore, Australia, and even cases coming out of Africa. I already mentioned we're waiting for data about smoking risk and how it affects disease outcomes. And then finally, why are our risk factors different? Once the data are all reviewed, I'm not sure we will see much difference at all. So time will tell. Next slide. Are people with diabetes at risk for COVID? I think there's a lot of information available to us that suggests people with diabetes are at increased risk for severe COVID. But again, as I mentioned in the beginning, this doesn't mean every person who has diabetes will develop severe COVID. In fact, the data suggests that because the background rates of diabetes in our society are very high, we are not seeing high rates of COVID infection or COVID disease in people with diabetes. There's also a question about whether or not people who are taking certain medications, such as angiotensin converting enzyme inhibitors, are at increased risk for severe disease. But this is to be determined. We need more research in this area, and I'm showing here a study looking at this. The study was not definitive, but they're looking at the link between the medications and COVID outcomes, because in people who take this medication, there's an increase in this enzyme, which is found in the lung. But that's really as much as we know right now. We really need to conduct more studies with a lot more people before we can make recommendations about people who take ACE inhibitors. So if you're on an ACE inhibitor, and you might be, we recommend discussing this with your provider and not discontinuing the ACE inhibitor based on this very preliminary information. Next slide. I'm sure you've heard a lot of advice about what you should be doing, and you'll hear a lot more in the course of this webinar. But these are just reminders. Practice social distancing, and 6 feet is the magic number, because when someone coughs or sneezes, the germs or the spray can travel up to 6 feet, but it's usually a lot less than that before the spray or the germs fall to the ground. Continue to take good care of yourself. I know this is a very stressful time, but find outlets to relieve stress. Stay in touch with friends and family members. Do things you enjoy. Even though in many places we're sheltering in place or staying at home, you can still go outside. You can exercise and stay well hydrated. And I like to tell people to sit quietly for a few minutes, at least once a day, because we are bombarded with so much information, particularly the media. I often wonder, what happened to all the other news? Now we are only hearing about COVID, and we need to take a break from it. So sit quietly for a few minutes, at least once a day, and minimize your screen time. And then finally, I'd be remiss if I didn't emphasize the urgent need for hand, cough, and sneeze hygiene, using a tissue or the crook of your elbow to avoid spreading infections. But please wash your hands. Thank you very much.
Thank you so much, Dr. Fitzpatrick. Dr. Peterson is a professor of medicine at the Keck School of Medicine at UCLA in USC in LA, and director of the USC Clinical Diabetes Programs. She previously directed the clinical diabetes programs at Cedars-Sinai and UCLA. Her research has focused on testing new approaches for diagnosing and treating diabetes and developing systems of care to improve outcomes in diabetic populations. She has published over 200 articles and reviews and abstracts and 3 books on diabetes. She has been an investigator on over 40 research studies and has spoken at over 400 programs throughout the US and internationally. She has served on many committees for the American Diabetes Association and other organizations. Anne, thank you for joining us.
Thanks for having me. So I think that my first headline for everybody is that I'm out here in the trenches taking care of lots of patients. And I've taken care of a number of patients with COVID-19 with diabetes. And I can tell you that all of my patients, young and old, with comorbidities and without, have all done well. So I just want to point out that people can have diabetes and COVID-19 and have good outcomes. So I know it's possible, so I'm going to try to help dispel some of the fear. And could you move to my first slide, because I can't seem to do it. All right, let's see if I can move it. I still can't move them. So next slide, please. So the CDC has a definition of high risk for COVID-19. And just let me point out that things change so much that data I'm showing you from 3 days ago may be different. But the people who are at higher risk, according to the CDC, for severe illness include older people and people who live in a nursing home or long-term care facility. And then there are a whole bunch of other high-risk conditions, and it includes obesity, defined by the CDC as a BMI of greater than or equal to 40, or underlying medical conditions, particularly if not well controlled, which includes diabetes. But I think more recent data, basically looking at patients who are more or less likely to be hospitalized for COVID-19, don't show that diabetes is an independent risk factor, but that once you are hospitalized with COVID-19, diabetes may portend worse outcomes. And that's probably because people with diabetes also have a number of different comorbidities, and the more comorbidities you have, the worse you tend to do. We have no data in a general population, just looking at random people with and without diabetes and their risk of having, say, more mild forms of COVID-19. But obviously, having better control of glucose levels is probably related to doing better in general. So the next slide, please. This is data that looks at, whoops, go back one slide, please. So the slide we just had is 21 patients who were hospitalized in Evergreen Hospital in Washington State. And it just basically looks at the patients in the ICU, what comorbidities they had. And you can see diabetes is one of them, but also COPD, end-stage kidney disease, chronic kidney disease, sleep apnea. There's a whole bunch of comorbidities here. So in the patients who were sick enough to be hospitalized, about 86% had one or more comorbidities. Next slide. This slide looks at patients who are hospitalized in China, and basically, simply put, it's how many people died versus recovered. And they looked at risk factors for dying, for not surviving the hospitalization. And age is always a risk factor in these analyses, being male, having comorbidities. They looked at other patients with hypertension, lung disease. Diabetes didn't reach statistical significance, but in other now analyses that are coming out, that is a risk factor as well. So once you're in the hospital, having other comorbidities, including diabetes, portends doing less well. Next slide. This is just a caveat, is that there are 2 interesting studies that have come out not related to COVID-19, looking at ARDS, which is part of the pulmonary process that happens in patients with COVID-19. And in these studies, this one looks at over 4,000 people and is pretty good quality evidence. Diabetes itself did not increase the risk for this bad pulmonary complication of ARDS. So that at least is slightly comforting to people with diabetes. Next slide. So these are my concerns. Everybody says, am I at increased risk? Well, we don't have a lot of data, and we particularly don't have data for well-controlled patients who may be younger, who don't have comorbidities. And I would say that in general, those are probably not at higher risk for developing COVID-19 infection, although we don't know. But clearly being older, having more comorbidities, and potentially poorly controlled glucose levels may put you in a higher risk category for getting it. I don't know that for sure, but I do think that that is clearly correlated with worse outcomes if hospitalized. And having diabetes in general can make being ill harder. If you're not eating, if you're vomiting, if those kind of symptoms exist, it can make diabetes management more difficult. Next slide, please. So this is my advice. If you have type 1 diabetes, you need to be prepared. If you're on a pump, you need to have a backup plan. You need to not run out of insulin. You need to have strips, meter, lancets. You need to have everything to manage your diabetes. If you're on high-tech devices, you need to be prepared to have low-tech management. You need to have ketone test strips, glucagon, and if your doctor prescribes it, medications that prevent throwing up or feeling nauseated. I have not had a single patient with type 1 diabetes develop COVID-19. I've had a number with type 2. And in LA County, in the county healthcare system, we also have not seen an increase in cases with DKA with type 1 diabetes. So I actually am feeling like my patients with type 1 diabetes have been proactive, have really done a lot of social distancing and are taking care of themselves. But I think there are a few key points. One, patients who have diabetes who go into ketoacidosis are having a harder time being treated because it's hard for the nursing staff to actually go in and do finger sticks. Everybody's now in the personal protective equipment and they don't want to keep taking it on and off. So we've had a hard time getting enough finger sticks in patients who happen to be in DKA. So first, follow sick day rules and avoid being in DKA. But if you go to the hospital, have a kit. And that kit should contain such things as meters and strips, extra sensors, charging cords for devices, things that you might need to monitor your own sugars if you happen to be in the hospital. I also recommend stopping SGLT2 inhibitors if you're on one at the first sign of illness, and then other medications as well, because in the hospital, type 1 diabetes, or even not in the hospital, should primarily be treated with insulin, particularly stop SGLT2 inhibitors. And then if patients develop ketoacidosis, don't delay going into the hospital, because one of the problems I know others have seen is people who delay going to the hospital when they're sick, they need IV fluids, and they end up being much sicker when they get there. So try not to get sick with type 1 diabetes in particular. Try to avoid ketoacidosis by giving insulin, by consuming carbs. But if you get really sick and you talk to your healthcare team, I would suggest going in for IV fluids just like you might under normal circumstances. Next slide, please. For people with type 2 diabetes, and I said I've had a number of patients now with COVID-19 and type 2 diabetes, I recommend holding the SGLT2 inhibitor at the first sign of illness if someone's on that agent. If people are on medications that can lower glucose levels like sulfonylurea agents or insulin, I think people should test their glucoses. In most of the patients I've seen, they actually don't develop that insulin resistance that I see, for instance, with the flu. I actually see glucose levels get lower because people aren't eating as much. So I think it's important to monitor and work with your healthcare team. Obviously, if glucose levels go up, you may need more insulin, but in my experience, glucose levels have been not elevated. People need to drink lots of fluid to avoid dehydration because dehydration can be an issue. And then don't stop any other medications, including ACE inhibitors or ARBs, unless advised by healthcare providers. All of this and all of the data is changing, so keep updated, but don't panic. As I said, I've seen lots of people now develop COVID-19, have milder infections, who've done, pretty darn well. It just requires monitoring and being in touch with your healthcare team. Obviously, this can be a very serious illness. People can end up in the hospital. But I have had good outcomes thus far, and I really encourage people to work with each other, to work with their healthcare team, and follow all the CDC recommendations about social distancing and avoiding getting the disease in the first place. Thank you.
Thank you so much, Anne. Really appreciate your insights. Next, we have Kelly Close. So Kelly Close is the founder and chair of the board of the Diatribe Foundation, a not-for-profit dedicated to improving the lives of people living with diabetes and prediabetes and advocating for action. Since 2006, she has been the editor-in-chief of Diatribe at diatribe.org. And she also runs Close Concerns, a healthcare information firm exclusively focused on diabetes and obesity. Kelly is recognized as an expert on diabetes and obesity markets, and she is a frequent speaker on the public health implications of diabetes and obesity. Kelly's passion for diabetes comes from her extensive professional work, as well as her personal experience as a type 1 diabetes patient for nearly 30 years. Please learn more about her at diatribe.org. Kelly?
Thank you so much, Sarah, and thanks for having me here. I just want to start, and I think I can advance the slides if you can advance the slide for me, please. I just want to start by saying, a while ago, my friend David Lee Strasberg, who's the creative director of the Lee Strasberg Theater and Film Institute, he told me that the natural human state is vulnerability. And that was an interesting thing for him to say and for me to hear. And now this pandemic has really revealed the truth of that statement. So, to ask patients, to ask how patients are experiencing COVID-19, we're witnessing a lot of different, kinds of vulnerability in so many different ways. And I think it's just important to recognize that vulnerability for disproportionately, this vulnerability, for disproportionately more of us. Many people with diabetes, that vulnerability is really amplified, and it's all of it. It's the stability of our work, it's our mental and emotional well-being, it's the safety of our families, it might be kids if we have kids, it's parents for people who have parents still. It's how we're thinking about the future of our health. It's how we call Walgreens and figure out if it's still open. It's how we reach our doctors. And I think lots of people with diabetes already feel stretched, and this is kind of cascading in a way that I think that I guess it feels like for those with health problems like diabetes might feel a little relentless. And I think all of those vulnerabilities are really somewhat normal to feel are probably feeling amplified right now for those of us with diabetes about how easy is it to find the right food to eat. Is the food stable? How long can it stay fresh if we take medicine? Do we have the right medicine in stock? Do we have the healthcare supplies that Dr. Peters was just talking about? The Virta Health Clinic is so inspiring. Not everybody has it. I love seeing how the Virta Health Clinic has already been thinking about telemedicine for so long, and this is a moment in time that's changing. And I think for patients to be able to access telehealth is also really positive. But I guess kind of the uncertainty of these times asks people with diabetes to be especially attuned to our diabetes management. At a population level, COVID-19 has already taught us so much about what is possible when the world aligns to a common goal, something that the diabetes and obesity epidemics should also demand. So there's no destiny, like Dr. Peters was saying, that if you have diabetes, you automatically have a higher risk of contracting COVID-19. But it does put more of a premium on all kinds of diabetes management, like she was saying, blood glucose, short and long-term complications, mental health. The more time that people can get their blood glucose curves in range, the more prepared they're going to be to handle infections like COVID-19. We've heard that from a lot of doctors. And while that's far easier said than done, this is what the virus is asking of us short term, to look at our blood sugar control and to see if we can improve. And although I'm not sure if we're listening yet, long term it's asking us to look at our hearts and kidneys and brains to see if we can improve those too, long term. And these are big requests. But when we think about it, when we ask the question, what is the pandemic requiring of us? I just kind of look at it, what's in our control and what isn't in our control? What do we know? What's knowable and what's not knowable? If we have access, can we be prepared with 90 days of supplies? If we're lucky enough to have that already, that's awesome. If not, if we can ask our doctors, if we're lucky enough to have doctors We're just trying to think very expansively. Maybe it didn't occur to us to ask for that before. Having our blood glucose strips and meters available, having maybe this is the time to ask a doctor for access to CGM. That's one kind of CGM. There are multiple kinds, but CGM is also something that can help us, even if you can only use it once, to figure out how you're doing continuously. That can be really valuable. You can talk to your doctor about if that might be something to try, continuous glucose monitoring or CGM. You know, there's a bunch of other things that we need depending on what our diabetes, what kind of diabetes we're asking for. We just want to make sure if we need ketone strips, if we need glucagon, to do everything that we can. I also just think for us all to just pause. You know, everything is looking a lot different now, as everyone on the planet is experiencing in many different ways. Some people are in grief because someone close to them, or more than one person close to them, has died. You know, someone's sick. Some of us have COVID-19. I'm lucky enough not to have it today, that I know of. But, you know, someone's trying to move hospital. We might be lucky enough, on the other hand, to try to figure out new ways to use our time. And if we're lucky enough to have jobs at all, and lucky enough to have jobs that allow that, that's awesome. And just to know that that's not the case for everybody, but wherever we are, especially if we have at least one other person around us who's helping us be our best self, one thing that COVID-19 gives us is an opportunity to try to get our house and our diabetes management in order. And if we don't have that person, by the way, or that strength, then we worry. And so to understand that about patients also. If we can go to the next slide. I think just as people with diabetes, some of us are lucky enough to have a new tool. It's called continuous glucose monitoring. I mentioned that explicitly because it can work very well for people new to diabetes or people trying to prevent diabetes. We all have the opportunity to learn about our blood sugar time and range, which is how we experience it on a minute-by-minute basis. You can look at your time and range through what's called a CGM report. There's a picture of one of them. I guess that's giving it to you backwards, but you can look at diatribe.org/TIR, and you can learn more about this. You can also do this with a blood glucose monitor if you have the ability to use 6 strips a day, and that'll take about a total of 6 minutes, and you can learn more about how to measure that. And then how to use that to figure out, how is food affecting you? How does exercise affecting you? How is sleep? What does this highly processed carb do? What does cauliflower do? If I can go to the next slide. Thank you. This one's fast. It's just to say, you know, what can we all do to be, you know, to learn how to be healthier? We can all learn to be healthier. If I can go to the next slide, please. Just wanted to say about time and range, you know, if you can improve, you can learn about time and range, and if you can improve your time and range, and we'll even go one more slide. Thank you. Those are just some different measures of it. But if you can improve your time and range by 5% wherever you're starting, then that's an hour more of healthy living a day. And if that hour is the hour before you go to sleep, then that 1 hour has the potential to turn into 7 more hours of health, or 4 or 5 hours more, you know, or however much you're able to sleep right now. But by working to actively track and improve our time and range, we can not only prevent hypoglycemia and hyperglycemia, we can add an hour's worth more productivity or an hour's worth more of feeling calm. Just, it's hard to imagine anyone not wanting that, particularly at that moment. The next slide, please. I just want to talk quickly about what else does this pandemic demand of us. And I think it demands of us, you know, it requires us to re-examine the role of food, and that's at both an individual level and a systems level. At the individual level, food really has the power to prevent and manage diabetes and help us manage threat of complications, or complications that we might already have. And the evidence is clear. The less carbs you eat, the more regulated your blood sugar can be, the more time you can spend in range. We know there's a new book out called Fast Carbs, Slow Carbs. That's by Dr. David Kessler, and I really encourage people to look at that online and learn about what are the carbs to avoid. We have gotten so much out of this ourselves, learning about how food can make us healthier at Diatribe. We know at a population level, our food system is broken. So it's clear the lack of access to healthy foods and the prevalence of soda and processed food that has a link to the diabetes and obesity epidemics that we face as a nation. It has been so energizing to see companies like Virta, life insurance, companies like John Hancock invest in diabetes prevention, not only to help people as individuals lead healthier lives, but also to reduce the strain of diabetes on our healthcare system. That's our job. There should be a war on diabetes. If we can click to the next slide, there are a bunch of barriers we know to healthy eating that have always been there, related to cost and availability and access. What can you all do as employers, payers, people with diabetes within the broken system? You might have the power to enable your workplace wellness programs if you're a company, or to promote healthy eating and exercise behaviors for employees or customers. Here again, the evidence is crystal clear. Even though these might seem like healthy costs up front, they are truly investments that pay themselves back over time. By recognizing that food is the most holistic medicine when it comes to diabetes, and by giving our bodies proper nutrition that we deserve, then we are capable of regulating our blood sugar and achieving higher time in range. That reduces our risk for all kinds of complications, maybe even those of COVID-19. So the courageous act of prevention today is both practicing healthy habits and enabling others to practice healthy habits. And you can go to diatribe.org to learn more about food in particular on that. This just shows, people really care about time and range. They are caring about being able to do the right thing no matter what kind of diabetes they have. And food is really stabilizing. Taking the right medicine is so important, and it's very stabilizing. And if you think you might not have the right medicine, please ask your doctors what you can do to help your glucose and long-term complications related to heart and kidneys. The next slide, please. Those are just some details that employers can see, and payers that are important. If we can keep going to the next slide, that would be awesome. It's just to say the silver lining of COVID-19 is really seeing so many different stakeholders come together to flatten the curve. If we could put the same level of focus and energy into diabetes, what could we be changing? At Diatribe, we would love to see everyone, employers, policymakers, manufacturers, payers, food leaders, aligned toward health, putting more emphasis on doing as well as possible, more focus on risk management in our diabetes, and focusing on diabetes prevention in a similar way. Tools that enable more time in range, and programs that promote healthy eating and mindsets and exercise and sleep. That's investments in the better future. That's all about Adam Brown's book, Bright Spots and Landmines. COVID-19 has highlighted vulnerability in so many senses of the word. Adam really helps us think about how we can do better. And as we know from many of our healthcare infrastructure challenges, we need that. It's all in our best interest to learn from COVID-19 and to address the diabetes and obesity epidemics now. Our website has several other resources about COVID-19 and diabetes. I hope that you'll go to diatribe.org. I just want to thank Virta so much for putting this together. What an honor for a patient to be on this distinguished panel. To say, we know we're hearing from DQ&A, patients are coming back, they're having a hard time getting supplies, not even because of global supplies constraints, but just because everyone is moving a little differently, whether it's Walgreens or doctors or whatever. So hang in there, do the best you can to be your best self. And thank you so much, Sarah.
Thank you so much, Kelly. So next we have Dr. Bob Radner. So Dr. Radner, we are happy to say, comes to us today as the Chief Medical Officer of Virta Health, which is a brand new position for him, and we welcome him with open arms to our team. Dr. Radner was previously the Chief Scientific and Medical Officer for the American Diabetes Association and is a professor of medicine at Georgetown University Medical School in Washington, D.C. He has served on the board of directors of the National Certification Board for Diabetes Education and the American Association of Diabetes Educators. He was a principal investigator for the Diabetes Prevention Program, or DPP, and DPP outcome studies of the National Institutes of Health, and served on the steering committee for the project nationwide. He is the author of more than 120 original scientific articles and 20 book chapters. Thank you again, and welcome, Dr. Radner.
Thank you, Sarah. It's a pleasure to be with you. As you mentioned right at the introduction, things are moving so quickly that the level of data are really problematic. So let me give you some perspective on that. On February 24th, JAMA published some early Chinese experience with COVID-19 and diabetes. What they saw was that the overall case fatality rate for COVID-19 was 2.3%. But the case fatality rate for those with diabetes and COVID-19 was 7.3%, 3 times as high. Essentially, diabetes gave individuals the same risk of dying of COVID-19 as an individual without diabetes who is in their 70s. 2 weeks later, The Lancet on March 9th published some additional data specifically on mortality associated with diabetes. What they saw was that 19% of the individuals hospitalized in China in this one institution had diabetes. But that 19% of the population with COVID contributed 31% of all deaths. Only 14% of the individuals with diabetes ended up surviving. More recently, in an online publication in The Lancet, the Wuhan hospitals published data on 1,500 cases of COVID-19. Approximately 10% of this population had diabetes, which is also approximately the prevalence of diabetes in China. This goes to Dr. Peters' point earlier about whether or not individuals with diabetes are actually at increased risk for developing COVID-19. The data that we currently have would suggest that there is no increased risk. Individuals with diabetes develop the disease at approximately the same rate as the population as a whole. However, this analysis showed that individuals with diabetes were twice as likely to require ICU admission and had a 20% mortality rate as compared to the non-diabetic population, which had a 10% mortality rate. This study was also the first to actually look at the relationship between glucose and complications of COVID-19. What they saw was that the admission hemoglobin A1C in those individuals with diabetes who survived was 7.9%, as compared to those individuals who succumbed to COVID-19 being admitted to the hospital with a hemoglobin A1C of 9.9%. This is the first data that I've seen that really relates glycemic control to outcomes in COVID-19. In fact, what they were able to do was to look at a receiver operating curve analysis to see what the predictive value was of glycemic control for survival. And what they found was that at a threshold of 180 milligrams per deciliter, you had an 80% sensitivity and a 73% specificity in predicting mortality. That becomes critically important. The most recent data comes from the CDC in their weekly morbidity and mortality journal, which came out yesterday. What they found in the US was that 11% of individuals presenting with COVID-19 have concomitant diabetes. Again, this is consistent with the prevalence of diabetes within the US, suggesting no increased risk of developing the infection simply because you have diabetes. However, the breakdown in the US would suggest that 42% of individuals with diabetes can be cared for in a non-hospitalized setting. 32% require hospitalization, but don't require ICU care. 19% of individuals with diabetes developing COVID-19 ultimately end up in the ICU with severe disease. So what are the final recommendations as of yesterday from the CDC? The typical issues about social distancing, washing your hands, clearly continue to play a critically important role. But specifically what they recommend is having at least a 30-day supply of medications on hand in order for self-care, and a 2-week supply of food. And finally, it is critically important to maintain glycemic control, even in the absence of infection, in order to improve the likelihood of success if, in fact, you're unfortunate enough to develop infection. So I encourage all listening to continue to push good glycemic control on all individuals with diabetes, regardless of their complications of COVID-19. Thank you very much.
Thank you so much, Dr. Radner. We are now going to move to Dr. David Harrison. Dr. David Harrison is dual board certified in internal medicine and pediatrics and is vice president of clinical care at Virta Health, where he leads the medical team and runs Virta's network of clinical quality initiatives. Dr. Harrison has worked in different areas of virtual care and telemedicine for over 10 years, serving as medical director and vice president of clinical quality for Best Doctors, and then as vice president of physician affairs for Teladoc, the world's largest telemedicine organization. In addition to his work with Virta, Dr. Harrison maintains a busy internal medicine and pediatrics primary care practice at Massachusetts General Hospital. Thank you again for joining us, Dr. Harrison. Over to you.
Thank you so much, Dr. Hallberg. The world around us is changing so much, and I believe there is no one who represents transformation more powerfully than Optimus Prime. More seriously, though, the previous speakers have outlined the challenges that many people living with diabetes are facing. However, as the proverb goes, necessity is the mother of invention, and the COVID-19 pandemic has accelerated the movement of telemedicine from the periphery of our healthcare system to center stage. Changes that would otherwise have taken years to occur have erupted in the span of a few weeks. This has important implications for, and I believe, holds tremendous promise for millions of people living with diabetes. Next slide. So first, I will provide a brief overview of the recent public policy changes catalyzing the rapid transformation of telemedicine. I will touch on how and why telemedicine can improve the clinical quality of care. I'll highlight the tremendous promise of continuous remote care in managing diabetes. And finally, I'll leave us with some important questions for the very near future. Next slide. So we are faced with bursting emergency rooms and overwhelmed hospitals. Crowded waiting rooms have become more dangerous to patients because of the significantly increased threat of contagion. Our healthcare system is not sufficiently prepared. In the military, a quick reaction force is called in to respond to rapidly developing situations. And one of the most important QRFs in our battle against COVID-19, telemedicine. Next slide. However, to optimize telemedicine's efficacy and scalability, burdensome regulations first had to be addressed. The pandemic has resulted in emergency declarations by all 50 states, which provide greater flexibility in responding to this public health emergency. As a result, more than half of state medical boards have either implemented temporary rules for expediting state licensure or have completely waived state medical licensure requirements. And it's critically important that telemedicine providers be able to deliver care to some of the nation's most vulnerable populations, the elderly and the socioeconomically disadvantaged. To this end, Medicaid and Medicare have issued Section 1135 waivers, enabling out-of-state providers to deliver care to Medicare enrollees, and at least 35 states have waived state-specific Medicaid registration requirements. The U.S. Department of Health and Human Services Office for Civil Rights has significantly relaxed HIPAA rules as they relate to telemedicine. So can I perform a telemedicine visit in the middle of Whole Foods using TikTok? No. But can I now use a non-public facing platform such as Apple FaceTime or Google Hangouts that's not yet fully compliant with HIPAA rules? Yes. Medicare, very importantly, has also led the way with incentivizing telemedicine, and many private insurers are following suit. Medicare will now pay for office, hospital, and other visits furnished via telehealth with equal reimbursement as is paid for in-person visits. I would not have expected that for years to come. The Centers for Medicare and Medicaid Services also has created 2 other billable visits, virtual check-ins and e-visits, the latter of which are asynchronous visits via patient portal. Next slide. A critical question, of course, is if the quality of care delivered via telemedicine is comparable to the quality of care provided in the office setting. I believe that it is, and in some respects can actually surpass the quality that is provided in traditional brick and mortar settings. To understand this, it's very helpful to consider the 6 domains of healthcare quality put forth by the Institute of Medicine. In a world in which going to the doctor's office presents risk, telemedicine can offer greater safety. When people can quickly access care from wherever they are physically, timeliness and efficiency are improved, and meeting patients where they are personally supports patient-centeredness. There are thousands of studies on the effectiveness of telemedicine, but still more are needed to understand both the potential and the limitations of virtual care. And with adequate support of patient-facing technology, telemedicine can be a great boon for health equity, increasing access and supporting delivery of quality care across all geographic locations, genders, ethnicities, and socioeconomic statuses. Next slide. In this environment, especially exciting is the opportunity to transform our current paradigm of caring for patients with diabetes. As Dr. Hallberg mentioned, I'm a primary care physician, and I've been providing primary care to patients at Mass General for 15 years. I love providing care to my patients with diabetes because I genuinely care about them, but not because seeing them every 3 to 6 months, ordering some blood tests, tweaking some medications, lather, rinse, repeat is either a satisfying or particularly effective paradigm for care. Now, of course, traditional medical practice is not quite a checkout line at Target, but sometimes it feels that way. Next slide. How much better and how much more awesome would care be with a continuous remote care paradigm in which physicians are empowered by telemedicine technology to man metabolic mission control centers? This is entirely possible, and this is what we are doing every day at Virta Health. Next slide. In Virta's continuous remote care paradigm, numerous patient biomarkers and clinically relevant symptoms are acquired via a patient-friendly app. These data are then assimilated by an AI-enabled clinical platform, bringing first to physicians' attention those patients whose biomarkers or symptoms demanded: blood sugar too high or too low, blood pressure too labile, decreasing energy or increasing carb cravings. Algorithms support the evidence-based management decisions and hardwire safety processes. And then, most importantly, this all drives real-time physician care, enabling a single physician to round virtually on thousands of patients and more rapidly and safely attain therapeutic targets. Continuous remote care makes so much more sense than what I do in my primary care office, writing a prescription and waiting for 3 months or longer to see the impact. And that's if the patient actually takes the medication consistently. Continuous remote care enables those patients who need care in the moment to receive it And it also safely allows for conservation of healthcare resources when active management is not required. To me, it's eminently clear. Continuous remote care is a better paradigm for diabetes and metabolic health management than the current standard of episodic office visits. Next slide. So the world of telemedicine has changed more in the past few weeks than anyone could have imagined. Questions remain, though, about how lasting these changes will be and in what further directions they will progress. Will patient expectations about healthcare and telemedicine be changed forever? Which of the temporary emergency public policy measures will remain post-pandemic? How can in-person care and telemedicine complement and support one another? It's not an either or, it's a both and. The more patients who can be supported by telemedicine, the more time physicians have to manage in person those issues that need hands-on care. And as we marvel at telemedicine's expansion, we need to ask ourselves, will we only seek to recreate a virtual version of our current episodic care paradigm, or will we use this opportunity to advance new, more effective paradigms such as continuous remote care? My sincere hope is that we will do so. Thank you so much.
So I will just go through and ask everyone a question right now, and then we'll see how we're doing on time. All right. So we'll begin with Dr. Peters. So what are the most common concerns that you are hearing about from your patients?
Well, the most common concern is fear that because they have diabetes, they're at increased risk for getting COVID-19. And as you've heard everybody say, there's no data that suggests that. There is, as we've talked about, if you get really sick and you're in the hospital, having diabetes can be a bad risk factor. But as I've seen lots of my patients with type 2 get it and do fine. So, you know, my experience is what the statistics show, which is that most people with COVID-19 are going to be fine, and you don't have to put people with diabetes in a bubble, except for the bubble I put everybody in who's older, who has cardiovascular disease, who has all the other comorbidities as well. But my younger healthy patients, I don't want to get it, but I'm not scared. I just am practical. Let's prepare you to prevent ketoacidosis. Let's prepare you to not run out of medicine. So to me, that it's key to feel like you have some control. And I think everybody with diabetes has some control here. And I'm not excessively worried about my patients, but I want to give them the support I can to just get them through.
Can I ask one other question, which is something that we've been hearing about in the media, about what medications you should or shouldn't be taking? And we've talked some about the medications that you should be continuing. But are there any medications that people should be taking now that they weren't previously?
Well, the answer is we don't know. And there's been a suggestion that chloroquine or hydroxychloroquine, with or without azithromycin, might help spare people, help them get rid of the virus sooner. But those are just suggestions, and they're from some trials that they did in China. And we don't really have any definitive data for sure. So I would not start taking something new now or stop taking anything except an SGLT2 inhibitor if you're on it and you get sick. But don't start or stop anything without talking with, you know, your healthcare provider. There are patients who've gotten secondary kinds of bacterial pneumonia who might need an antibiotic. But again, nobody should just go jump on medications, and nobody's preventing people from doing that, but we just don't know. And I think right now, everybody has to be looked at on a case-by-case basis. I have not started any of my patients with COVID-19 on anything new. I have just, you know, helped them, watch them, and, you know, as I said, they've done well. So don't go crazy about new things. When there's new things, we'll find out, but not yet.
Thank you. Thank you. This question is for you, Kelly. And you mentioned getting medications ahead of time, but how much medication should people be obtaining? And have you or your team heard of any shortages of specific medications occurring?
Yeah, actually, because obviously this group of patients is so heterogeneous, there's a lot of different experiences that people are having. DQ&A, our sister organization, actually just wrote about that this morning. That they asked this question over the weekend to thousands of people. I think 4,000 people came back and said, by and large, the problems don't seem like they're in the supply chain. Kind of 80-ish%, a little more than that, we're doing okay. And then, another 10% in certain ways, we're having some different problems, maybe that were stemming from a drugstore or mail delays, or like it's harder to get in touch with their doctors. I mean, Anne is working 24/7. Everyone is so stretched right now. So they're kind of more secondary problems. I mean, if you're lucky enough to have insurance, and good health plan and all of that, I mean, if you can try to get 90-day, great. But Bob said, making sure that you've got 2 weeks of food, 4 weeks of medicine. That's what our goals should be. I don't know if Bob or Anne has anything else to say about that, but what I'm hearing from patients is kind of fear emanating from other parts, not because of any factories closing down or anything like that.
So can I say one thing? The hardest part for me right now is all the paperwork. So
Yeah,
if people need devices and they need, or people who are on the patient assistance program, for instance, it makes me crazy because I can't always print stuff out at home and mail it in. So it's the things that I can't do electronically, and that's the hard part for me in getting things for my patients.
Yeah, we would also say, there's diabetes disaster relief that the ADA has information about at their website, diabetes.org, and that's a slew of organizations working really hard on that. And I think the manufacturers are going way out of their way to try to make things as possible, as available as possible. They're bending over backwards. There are ads in the newspapers. There are many different ways of trying to get help.
All three of the insulin manufacturers have had ads in multiple publications saying that they will make insulin available to anybody who needs it. And they've got websites and 800 numbers if anybody is running low on insulin. So that, I think, is a major plus.
Yeah, diatribe.org/access. We actually have a whole article that was hundreds of hours of research into how to get drugs for free if you need them. But again, just to Anne and all of the doctors out there, thank you so much from us patients. And please, patients, also be patient with your doctors if you can.
Thank you. That was actually one of my questions. So such an important one to anyone who's concerned about getting or maintaining access to medication. So I appreciate that. And Dr. Radner, if I could ask you, what we are hearing a lot in the news about celebrities who have been getting tested for COVID-19. And one of the questions that I've heard a lot is, why is it so difficult for other people who may be higher risk to get tested? And what should they do if they're concerned?
Well, I can't comment on how the rich and famous managed to get their tests done. We've had a major problem in this country with having adequate tests available. This really is a supply chain issue. We haven't had the tests, we haven't distributed them. And as a result, they've literally had to be rationed. So the CDC several weeks ago came out with guidance on who should be tested. And it was very, very restrictive. It was individuals who were in nursing homes, individuals over the age of 65, individuals who had severe symptoms. And that just plain wasn't adequate. So we still don't know within the United States what the exposure rate is to this virus. If you look at South Korea as the ideal model, with it, they had their first case of COVID-19 exactly the same day as the US did. They've already tested the majority of people in the country. We just hit 1 million out of 300 million. So it's the access to the test, and it's the necessary rationing of the tests because of the inadequacy that has been the problem. Now, there have been a lot of new tests that have come on the scene. Some of them are even home tests that are now being looked at by the FDA, so you don't even have to leave your home in order to get it done. But as all of the experts have said, testing is critical. We need to gear up our capacity in the US to test as many people as we possibly can.
Thank you so very much. Dr. Harrison, what things are you seeing patients with chronic diseases doing that maybe they shouldn't be?
Well, to be honest, Sarah, it's more what I see them not doing, or treating their episodes of care with their doctor as these kind of isolated times during which to really pay attention to their overall health. And I think back to when I was a kid, and obesity was a problem for me. And I remember, maybe 2 weeks or so before going to the doctor's appointment, I would go and start dieting. And then after the appointment, on my way back home, I still remember my parents buying me a Hostess pudding pie. And then, I kind of just fall off the wagon. And that's something that, in managing my patients, I see again and again. And again, want to underscore that is why a paradigm of continuous remote care, where people are getting regular, ongoing, continuous feedback, biofeedback about how they're doing, is so important. And again, overall, the COVID pandemic is terrible. It's a crisis, and the number of people who have died is tragic. If there is any kind of positive thing that could come out of this, I think that the greater attention that everyone is paying to their own healthcare, especially those people with chronic diseases, that could be potentially a silver lining on what is a very dark cloud right now.
And Dr. Harrison, is it possible to see a physician in a virtual visit for an acute illness like an infection?
Oh, I absolutely. And I think back to the words of Sir William Osler, who's one of the most revered figures in medicine. And he had said, 100 years ago, listen to your patient. He is telling you the diagnosis. There's a tremendous amount in medicine that does require hands-on care, but at the same time, there is so much that can be done. If doctors really listen, they can understand so much about what is going on. And because of technology, more and more of the physician's office is can be brought into the patient's home. So, with the combination of physicians really becoming more facile at telemedical care and understanding what they can and cannot do in a medically responsible way, and the more and more that patients are able to access, glucometers and blood pressure cuffs and devices that auscultate the heart and lungs and all these things, we really can bring the doctor's office into the patient's home.
Thank you. And I just have one last question, very quick one. I'd love to get everyone's input in, which is, what is the one piece of advice you think is the most important for people who are struggling with diabetes to follow right now? Dr. Peters, can we start with you?
Well, I kind of agree with what Dr. Harrison just said. I've never had the capacity to connect with my patients more, and I've never seen them do better, especially my patients with type 1 diabetes, many of whom are on devices, but they're home. They're not going out. Their lives are pretty fixed. I've just seen the most beautiful tracings. I feel like everybody's just getting better. So I'm always an optimist. And I think the world is going to come back to some new normal, and what that new normal looks like will be different than it was before all this. But, the fear part is there, and it's real, and dealing with the psychosocial issues with this and anxiety is so important that people do. But, all of us can reach out to each other, and I think that we're a community of people who care about each other, at least those of us who are in chronic disease. And I think not reaching out is the one flaw. People shouldn't not talk to me. People should want to talk to me because I want to help them. So I see this as a time to be our best selves, not our worst selves, particularly with regards to diabetes. So I'm positive about this. And again, you know, I've seen all sorts of varieties of severity of this illness, and most people are going to be fine. I keep telling people this, with or without diabetes, you know, we'll get people through this. And yes, people will die, and that's horrible, but still, you know, there's got to be a positive energy.
I just have to interject and say, Dr. Peters, that I couldn't agree with that more. And what I've been communicating so much to my patients is this is the time to focus on you for once in your life, because we lose that time so much. So I absolutely concur. Dr. Radner?
Many of us years ago discovered that the primary care provider for a person with diabetes is the person with diabetes. And the role of the healthcare provider is really to educate, answer questions, and to support. And I think that what we can do right now is make ourselves available to our patients to answer their questions and to give them guidance. But as Anne is saying, if they're paying attention and they're able to pay attention to their disease, they're the best care providers.
Kelly?
Yeah, it's amazing. There's so many people who can watch videos of Anne online. I mean, Anne is such an incredible resource. So I think if you have the ability to have some more time, not everybody does. I hear you guys, like some people are way more stretched. But if you can tune in to doctors like Anne online and others that can help you to just try to be 5% better, just try to figure out how to be 5% better now. Food, exercise, mindset, sleep, diatribe.org/bright spots.
Dr. Harrison?
And similar as my colleagues on the webinar have shared, this is a time where for so many of us, the world seems to be spinning out of control. Our economic realities, our children's schools, everything, we can't control it. But for people with diabetes, it is not easy at all. It is easy to say, it's hard to do, but there is a tremendous amount that people can feel empowered to control. And that would be, that ability for people to take control of their lives. I often tell my patients in the office, it's time to unleash beast mode. The ability for people to say, okay, I'm going to do beast mode. I'm going to, have that healthy low carb diet. I'm going to be able to get outside, get some exercise. I'm going to pay attention to hand hygiene. All of that is in our control. And if we can hold on to that, I think that can help give us the courage we need to weather this crisis together.
Well, thank you so much to all of our panelists. We appreciate your time. And to you, Dr. Peters and Dr. Harrison, who are operating again on the front lines, not only gratitude for today, but gratitude for all that you're doing to help your patients and therefore, help the entire country in a way, because we have to be doing that through supporting the individual. So again, thanks to everyone for all you do, and we appreciate people joining us today. Be well and stay home if possible. Thank you.